Am I audible now?
Yes, you're audible.
Yes,
Yeah,
go
yeah.
ahead.
So, good evening, speakers, and everyone joining us today. It's a genuine privilege and honor to welcome you all to the Buyer Eyesight virtual meeting. Today, we are conducting this meeting on mainly on the aflibercept role of aflibercept. So, today we have two speakers. Our first speaker is Dr. Shobik Sen, sir is a renowned ear surgeon from Shushudai Hospital. And our second speaker is Dr. Anup Das. Sir is also senior ear consultant from Dishai Hospital. So now I formally welcome Dr. Shobik sir to start our meeting and hand over this session to Dr. Shobik sir. Thank you, sir.
Thank you very much. A very good evening to my peers, colleagues, and everyone who's attending this session. Today, I'll be trying to do something which is slightly novel, uh, maybe slightly imperfect also, but in with regards to anti-VEGF therapy in diabetic macular edema, to compare four molecules that are actually used head-on using all the studies, the clinical trials that have been done thus far, tabulate them, and try to do a comparison in various regards. So, in this, what we'll do is we'll compare the mechanism of action, pharmacokinetics, the VEGF binding profiles for all four agents, and appraise the efficacy and safety data from Protocol T, Vivid, Vista, RISE, RIDE, Kestrel, Kite, Yosemite, Ryan, and applying the grade evidence hierarchy. And also apply real world evidence, including the Indian registry data and post marketing signals, to individualize treatment decisions for DME in resource constrained settings. And construct, finally, a scenario specific four agent treatment algorithm accounting for baseline vision, OCT morphology, injection burden, systemic comorbidities, cost, as well as access. So, a general overview of the etiopathogenesis, what we're looking at is, for diabetic macular edema, we have a chronic hyperglycemia, type 2 diabetes, retinal capillary endothelial stress, followed by pericyte loss and immune cell dysfunction. Now, this obviously involves the following agents: VEGF-A, the primary mediator and the most potent blood retinal barrier disruptor; placental growth factor, which is synergistically works with VEGF-A and targeted by some of the molecules as well; Ang-2, which is a parasite stabilizer and blocked by faricimab, which is a novel target; and VEGF-B, and it has more of an emerging role in diabetic macular edema and plays a role in parasite survival. So moving on to the basic, characteristics. It's a For aflibercept, we know that it's a recombinant fusion protein. It has no Ang-2 binding activity. It targets VEGF-A, VEGF-B, placental growth factor 1 and placental growth factor 2, and it targets all the isoforms of VEGF-A. And the PGF binding is unique among non-bispecific agents for aflibercept. The binding affinity is actually 100 times greater than ranibizumab. And the durability, in terms of durability, we could achieve a Q8 maintenance as per the Vivid Vista studies established. Now, for ranibizumab, we know that it's a humanized monoclonal antibody antigen binding fragment. There's a VEGF-A pathway only for binding. There's no Ang-2, and it binds to VEGF-A in all isoforms only, and no binding with placental growth factor, VEGF-B. And there are various biosimilars that are available, as we know, and it has the lowest systemic exposure of all the agents due to the FAB fragment and linear clearance as well. And coming to brolucizumab, we have it's a single chain antibody fragment, humanized, and it binds VEGF-A again in all its isoforms. It doesn't bind with any other mediator, and although we've been able to achieve Q12 in 53% of the patients, eventually over 2 years, uh, it has a very high durability. Safety has been a concern, particularly with regard to IOI, retinal vasculitis, and retinal vascular occlusion, according to the ROVO studies, the ROVO studies, and the Merlin studies. So coming to faricimab, it's a bispecific IgG1 antibody which simultaneously binds VEGF-A and Ang-2. So it's unique, of course, because it blocks parasite destabilization independently of VEGF. And it's the only dual pathway agent. And since it binds both the VEGF-A and Ang-2 pathways simultaneously, it has the longest approval interval where we can achieve up to Q16 within the first year. In fact, about 50% or more patients can achieve this, and which is the highest among all anti-VEGF agents. So coming to I'm not going to go into detail through this table because this table takes what I've just said and it actually puts it in tabular form and compares them. So what I'd like to point out though is the last row, which talks about the systemic VEGF level. For aflibercept, the systemic VEGF level is relatively moderate. For ranibizumab, it's low. For brolucizumab, it's the lowest, and again for faricimab, it's moderate. This will come into significance later. So in terms of efficacy, when we're looking at what we could achieve at the end of 1 year, letter gain at 1 year, based on the Vivid study for aflibercept, we could gain a 10.5 letters on the ETDRS. For ranibizumab, based on the Vista study, we're able to gain 6.2 letters. For brolucizumab, we were based on the Kestrel study, we were able to gain 10.6 ETDS letters. And for faricimab, for the post-treatment interval, based on the eosamide, there was a gain of 11.4 letters. So again, in the year 2 outcome, comparing all 4 agents, they all reach 10 to 13 letter range, but with different treatment protocols. So for Vivid Vista with aflibercept, we could achieve 10.7 letters, but this is with a Q8 maintenance. So on an average, 9 injections per year. Now, for ranibizumab, based on the Rise and Ride study, we could get 12.5 letters, but the injection burden is higher. On an average of 13 injections per year, a Q4 weekly regimen, Q4 regimen. And for brolucizumab, again, with the Q6 regimen, according to the Kestrel study, we could get 11.6 letters of ETDRS gain, and 53% of them could get Q12 at 52 weeks. And 10%, 10 injections per year. And in terms of injection burden, of course, faricimab, we could do as well as 6 injections per year by year 2, and gain of 10.7 letters, 50.7% at Q16 by year 2. So you can see that they're all very comparable, but with different treatment regimens and with different injection burdens. So again, with regards to efficacy, if we're looking at the protocol T poor visual acuity subgroup, which was BCVA less than 20/50, the percentage of patients gaining 15 ETDRS letters or more at the end of year 1, with aflibercept, we could achieve up to 59%, which was phenomenally high. With ranibizumab, it's 38%. So there was a very significant difference. For faricimab and brolucizumab, there is a little bit of an evidence gap that's yet to be actually ascertained. So coming to, again, central retinal for the central retinal thickness, for brolucizumab, based on the Q6 regimen in the Kestrel study, in the year 1, we could get an average reduction, a mean CST reduction of 207 microns. With faricimab in the first year, it was 196 microns. Aflibercept, it was 195. Ranibizumab was the lowest at 128 microns. And by the second year, brolucizumab, it went up to 218 microns. Faricimab stayed constant at around 195 microns. Aflibercept did even better by the second year at 210 microns, and ranibizumab at 149, which is the lowest. So you can see that there is a significant difference in the first year in terms of brolucizumab had a higher CST reduction, but by the second year, aflibercept seems to nearly catch up, and faricimab remains more or less constant, but all remain fairly effective. So in terms of intraretinal fluid reduction, of course, we know that it strongly predicts visual acuity loss. VEGFR2 activation and blood retinal breakdown, all agents obviously targets these two mechanisms. and all agents reduce intraretinal fluid. Brolucizumab and faricimab in this regard had the highest elimination of intraretinal fluid. But the Protocol T morphology sub-study of 2016, intraretinal fluid resolution was the primary determinant for final visual acuity outcomes. So if intraretinal fluid persisted at 16 weeks or more, we retreat regardless of visual acuity, which is the preferred endpoint for treat and extend decision making across all agents. For subretinal fluid, there's less strongly correlated. It's less strongly correlated with final visual acuity than, of course, intraretinal fluid. And of course, in SRF dominant eyes, visual acuity may gain despite incomplete SRF resolution if we can reduce the RF intraretinal fluid, that is. So faricimab, based on the Yosemite study, was found to be very superior in SRF elimination in the post-treatment interval arm versus ranibizumab in the Q4 arm. But based on the Kestrel Kite study, brolucizumab was superior in SRF elimination versus later. So there's an evidence gap in terms of being no head-to-head SRF comparison across all four agents. So we have better data for intraretinal fluid. Now, again, when we're talking about efficacy in different scenarios, in different patient groups, so when we have patients with poor baseline BCVA, less than equal to 34 ETDRS letters, vision of 220 by 200, faricimab actually, based on Protocol T, performed exceptionally well with a gain in this subgroup of 18.9 letters. For ranibizumab in the same study, 14.2 letters. For brolucizumab and faricimab, there is an evidence gap, so it's difficult to compare. Now, in pseudophakic eyes, they didn't really find, none of the agents, they found a very significant difference between phakic eyes and pseudophakic eyes. The data remained relatively constant. Now, in terms of patients who had poorly controlled diabetes, where HbA1c was greater than equal to 8%, aflibercept reduced the IRF, but there were significant gains in visual acuity with aflibercept. Ranibizumab had higher CST but slower resolution. For brolucizumab and faricimab, again, there is an evidence gap. So again, for aflibercept, what we looked at with the first year, we were able to achieve for the injection dosing for the first year, we could achieve approximately after a Q8 weekly fixed dose interval, we could achieve a burden of 9. For ranibizumab at Q4, we could achieve at an injection burden of 13, which was the highest. Brolucizumab at 10, and faricimab with the lowest at 7. So faricimab, of course, at the top, but aflibercept not very far behind in this regard in terms of long-term injection burden. So again, for extending the in terms of what do you call it? The adverse events, sorry, the adverse reactions. What we had in terms of endophthalmitis risk for 2 years, over 2 years, for faricimab, it was around 0.63%, aflibercept 0.8%, for brolucizumab 0.83%, and ranibizumab, surprisingly the highest again, 1.2%. The other agents are relatively very similar. And again, this is coming to, we come to the injection burden. I showed the injection burden at the end of the first year. Now, for the second year, the total injection burden at the end of 2 years for faricimab was the lowest at 12.5 injections over 2 years. For aflibercept mating in Q8 regimen, 16 injections for in 2 years. Brolucizumab for a Q12 interval, 16.5 injections in 2 years, but with a caveat, brolucizumab having a significantly high incidence of IOI and vasculitis. This comes with fine print. We have to be careful while treating and extending with brolucizumab and extending for so long. And with ranibizumab in a Q4 regimen, we required 24 injections over 2 years. So one important thing that we have to understand is the clinical implication in terms of for durability. Aflibercept Q8 remains the most consistent and safest extended interval protocol. Faricimab post-treatment interval offers unprecedented Q16-week durability of 50.7 patients by year two. We can achieve Q16 in 50% of the patients or more by year two, with a clean safety profile, which is clinically superior to brolucizumab Q12 when patient can access treatment. For brolucizumab at Q12 is competitive on injection burden, but carries the risk of vasculitis. And ranibizumab's durability is limited by its FAB pharmacology. In resource-limited settings where monitoring visits are as costly as injections, faricimab PTI or aflibercept treat and extend offer the most optimal balance if faricimab cost is manageable. So again, coming to adverse events, when we compare all the four agents in terms of intraocular inflammation, vasculitis, vascular occlusion, endophthalmitis, intraocular pressure rise, and tractional complications, we see that in the first three rows for IOI, retinal vasculitis, and retinal vascular occlusion, all the agents are very comparable. However, brolucizumab stands out with an intraocular inflammation rate of 4.5 to 6%, retinal vasculitis rate of 3.3% based on the ROVO study, and the retinal vascular occlusion rate of 1.1% in the Merlin study. So this is where the limitation arises when we're trying to treat and extend with brolucizumab, even though it might have in certain instances very comparable durability and long-term CST reduction over 2 years in a study. In real-world settings, we have to be careful while using brolucizumab when the data suggests this adverse event profile. So now, again, coming to the ROVO study, in 2021, it's a retrospective analysis of 3,726 brolucizumab-treated eyes for NAMD. So retinal vasculitis had an incidence of 3.3%, retinal vascularization of 1.1%, severe vision loss in 50% affected. And this was actually comparable. The reason why, although this was done in NAMD, it was actually comparable to the incidence in diabetic macular edema as well. Now, coming to Merlin study, prospective randomized clinical trial, the brolucizumab, again, in the Q4 regimen, in NAMD, the vascular occlusion rate was 4.3%. Trial terminated early. DME vasculitis rates were slightly lower than AMD, but still significant regardless. Now, when we come to the Kestrel Kite trials, the phase 3 DME trials, the IOI was 4.5 to 6%, higher than all comparators. Vasculitis rate was 0.2% lower than NAMD reports, but still significantly high. The post-marketing real-world DME data is still accumulating. Faricimab comparison, Yosemite Rhine, no retinal vasculitis signal in more than 3,000 eyes. IOI 2.22 to 2.7%, comparable to ranibizumab. Faricimab offers comparable durability to brolucizumab Q12 weekly with superior safety. Now, systemic adverse effects. I think that one thing I could summarize here is that in terms of systemic exposure, brolucizumab has the highest rapid clearance, less than 30 minutes. Faricimab around 7 days, which is the longest. Aflibercept and ranibizumab were actually quite comparable, quite similar, around 2 hours. And in CKD renal patients, the main route of clearance for ranibizumab was renal clearance. For aflibercept, brolucizumab, faricimab, the clearance was mainly through the hepatic pathway. So these are preferred in effective GFR when it's less than 30. Again, in terms of other differences, the APTC differences between any agent, all trials were underpowered for this endpoint. There was no proper data collected for that. So for pregnancy and lactation, all agents, of course, are to be avoided. There's no documented safety data. Washout mandatory before conception. Now, again, comparing to a real, in terms of strategizing algorithmically, if we look at aflibercept, it's a preferred first line if efficacy is priority, especially in patients with poor visual acuity. For ranibizumab, it's preferred when cost access is limited, or when cost or access to higher end molecules are limited, or compliance with monthly dosing is achievable. And for brolucizumab, the use has to be very discretely selective. Durability might be a priority with robust monitoring and informed consent. So if you're looking for durability and is your priority, then it has to be done with robust monitoring and proper consent based on the data that we've seen. For faricimab, we can prefer faricimab when durability is paramount, cost is acceptable, and brolucizumab is contraindicated. So in real world evidence, again, the injection count gap. Now there's the randomized clinical trials that we do. We assume that there are certain number we come to the conclusion that the injection burden for the first year might be a certain number, for the second year might be a certain number. But in real world scenarios, what we see, for example, for aflibercept in the clinical trials, we might achieve, based on the RCT protocol, we might achieve 9 injections in the first year. But in the real world, the average that we end up giving might be around 5.3 injections. And for ranibizumab, we might need, based on the randomized clinical trials, 13 injections in that first year. But in reality, we might end up giving 5.1 injections on an average. For bolicizumab, again, that burden might be 10 based on the real world trials, but we might end up just giving 6.2. For faricimab, again, we might require 7 in the first year, but in the real world, not more than 5. So there is under treatment, there's a selection bias. Again, for the randomized clinical trials, we exclude elderly, high cardiovascular risk, poorly controlled type 2 DM, and there are monitoring gaps. There's, intensive OCTs in real world clinical trials are done, and in the real world, in the randomized clinical trials are done. In the real world, they are missed visits, so they're not regular OCTs, so there's untreated fluid. And many of these patients, based on the registry, they might start at a worse baseline visual acuity. So there's a late presentation that limits recovery. So the real world and the randomized clinical trials have to be rationalized and compared properly. So again, another problem is that 50 to 60% of DME patients tend to discontinue anti-VEGF therapy by year 2, regardless of agent. So this is based on the registry of 2021. Each missed injections equals to 1.0 ETDRS letter loss at year 1. So this is based on drcr.net analysis. More than 8 injections in year 1 achieves twice the BCVA gain versus less than 6. So this is based on the IRIS registry. And faricimab PTI's flexible interval Q8 to Q16 may improve adherence versus fixed monthly, and that's just preliminary data. In Eastern India, transport cost is a major barrier. Cluster injections on the same day plus OCT scheduling is essential. So there are other logistic factors that are involved in discouraging patients from continuing their injection regimens. So so again, the mean injection count, what we see, I think this is covering the same thing. And so if we look at if we try to rationalize this through an algorithm, when we come up with a new DME diagnosis, center evolving with BCVA reduced, we do a baseline BCVA assessment. Now, if the BCVA is 2040 to 2050, 67 to 74 letters, we could use aflibercept or ranibizumab biosimilar if cost is an issue. If the BCVA is greater than 2040, more than 75 letters, we can use a ranibizumab biosimilar since it's cost effective and equivalent, because there's not much difference when in terms of the outcomes when with aflibercept when the visual acuity is fairly good. And when the BCVA is less than 2050, less than 60 ETDRS letters, the first line ideally should be aflibercept based on the protocol T evidence. So if cost is a limit, ranibizumab biosimilar for all visual acuity tires A complete course is greater than a premium in a complete course of a premium agent. So even if you have a biosimilar, at least having a complete course of the biosimilar is better than having an incomplete course of an innovator molecule. And if durability is critical, plus of affordability also, consider uh, faricimab. If you want durability and it is affordable to you, you can consider faricimab and brolucimab only with full consent and monitoring infrastructure. So again, this comes back to the clinical data. So for all four agents, we know that they are contraindicated in pregnancy and lactation. Um, for faricimab, as an additional caution, there's no pregnancy data and it has the longest plasma half-life. So we have to be a little careful. And for washout, ranibizumab, approximately 2 months, aflibercept, approximately 3 months, brolucizumab, approximately 1 month, faricimab, approximately 3 months. For severe CKD, when effective GFR is less than 30, for ranibizumab, renal clearance is the main route. So theoretical accumulation risk even in dialysis. And aflibercept, brolucizumab, and faricimab, because the main pathway is hepatic clearance, it's preferred in when the effective GFR is less than 30. For faricimab, there's no dedicated CKD data, but IgG hepatic clearance supports use. So there's no randomized clinical data in dialysis patients for any agent. So we have to monitor clinically. Now, as far as the ACS stroke within 3 months, if there's an adverse cerebral vascular event, so we defer anti-VEGF until more than 3 months post event. Uh, Also, brolucizumab, preferably theoretically, because it has the highest washout, but there's a risk of vasculitis. Faricimab has a longer half-life again, so it's again not the preferred agent in this setting. Ranibizumab has a rapid clearance, theoretically a systemic advantage, but then still to be used with caution. So now, if we have patients with active or prior uveitis, brolucizumab is a relative contraindication. Vasculitis risk is dramatically elevated. Faricimab, no vasculitis signal so far. It's preferred over brolucizumab in uveitis. Aflibercept or ranizumab, proceed with standard precautions, suppress active uveitis before initiating any anti-VEGF agent. Now, for definition of non-response, we look at the couple of criteria. We look at CST reduction less than 10% from baseline after 3 monthly injections, a visual acuity loss of 5 letters or more despite adequate loading dose, persistent or worsening intraretinal fluid at 3 month assessment. So switching within the class anti-VEGF, we can switch to ranibizumab from ranibizumab to aflibercept based on the protocol C sub-study, because it supports visual acuity gain based on that study post-switch. We can switch from aflibercept also to faricimab because of the dual mechanism that of Ang2 pathway that might be unaddressed. And then we can switch from any agent to brolucizumab, but the risk of vasculitis being there, it must be discussed priorly with the patient, and it requires regular monitoring as well. And from faricimab to other agents, there's limited switch data, so consider aflibercept if efficacy is a priority. So let's look at faricimab as a switch target. Emerging evidence, anti-VEGF inadequate responders may benefit from Ang2 blockade. Rational Ang2 upregulation drives residual leakage in VEGF refractory eyes. Yosemite post hoc study shows that prior anti-VEGF treatment did not attenuate faricimab response. So clinical position, reasonable escalation if aflibercept or ranibizumab is insufficient. So again, we're looking at the injection burden in terms of the costs and the number of injections. So for aflibercept, year one with a Q8 interval, it's 9 injections. For ranibizumab biosimilar, it's 13 injections. For brolucizumab, it's around 10 injections with a Q6 interval. And with faricimab, it's 7 to 9 injections. So the cost, there is a significant difference for aflibercept, as you can see, to ranibizumab, to brolucizumab, to faricimab. But over time, I guess this injection burden, if we average out the costs, that gap does reduce. So in 2 years for aflibercept, we're giving usually, if given, if the patient follow-ups correctly, properly, and monitored, we are ending up giving an injection burden of 16, for ranibizumab 24, for brolucizumab 16.5, although again the caveat is a higher risk of intraocular inflammation. And for faricimab, it's the lowest, 12.5 injections. So the last row I want to focus on what the calculation has revealed. The ETDRS letter gain for aflibercept is around 18 to 22,000. For ranibizumab, it's around 9 to 4,000. For brolucizumab, it's 26,000. For faricimab, it's 32,000. If you look at it among the high-end molecules, aflibercept actually has the lowest cost per ETDRS letter gain, with very comparable results over 1 year and even more over 2 years, with low injection burden and especially very good in poor visual acuity of subset patients. So those are all the factors to look at aflibercept for. And this is again going into costs. I'm not going to. So there are financial barriers, there are infrastructure barriers, there are clinical barriers, there's system level barriers. The average injection costs in many parts is 50 to 60% of monthly household income for BPL patients. There's no universal insurance or intravitreal therapy. And hidden costs are transportation, accommodation, lost wages for rural patients. These have to be taken into account while accounting for injection burden. There's infrastructure barriers. OCT machines are available in less than 5% of district hospitals. Cold chain, all four agents require 2 to 8 degrees of storage throughout the supply chain. Sterile procedure suite requirements limits it to secondary, tertiary care only. Faricimab requires PTR protocol training, not yet widely adopted. Clinical barriers late in the real world. There's many patients present very late. Median 24 months from diabetes diagnosis to ophthalmology referral. Ophthalmologist density 1 per 1 lakh. The WHO standard should be suggests it should be 1 per 20,000. Poor glycemic control reduces anti-VEGF responsiveness for all agents, and faricimab PTI protocol requires more monitoring visit precision than fixed dosing. Then there's system level barriers. There's no national DME registry, outcome data fragmented across institutions, no standardized retreatment protocols across private or public divide, no ophthalmology not integrated into diabetic care pathways in primary health, and there's no pharmacoeconomic data for agent comparison in the Indian context. So based on this, I used a deep learning model to actually come up with a scoring system based on these different criteria, these different protocol. So in terms of this is one might have a subjectively different view, but this was done by a deep learning model that used all the data of all the studies in all these aspects. One is efficacy in terms of visual acuity gain, efficacy in poor subgroups, anatomical CST reduction. So when we see efficacy, aflibercept score, brolucizumab and faricimab score relatively the same, very high. The efficacy in poor subgroup, visual acuity subgroup, aflibercept does exceptionally well. There's an evidence gap for brolucizumab and faricimab. In terms of anatomical CST reduction, again, all these higher end agents, they do very well. Aflibercept, faricimab, brolucizumab, as we know, in reducing IRF is the most robust, so it scores slightly higher. For durability, all agents are very comparable, but in long-term durability, due to the reduced injection burden, faricimab scores higher than both aflibercept and brolucizumab. Safety protocol, brolucizumab scores even lower than the biosimilars, understandably so. All the others have exceptionally good safety profile. And the practicality and access, obviously, ranibizumab will score higher. It's more accessible. Faricimab, a newer molecule and being relatively more expensive, of course, the accessibility is less. Even so, for brolucizumab, aflibercept slightly better, but still less than ranibizumab. So there's the synthesis of what I've tried to put together. There's no single best agent. All four agents produce similar BCVA gains in full cohort analysis. Agent selection should be individualized by visual acuity, OCT morphology, cost, and access. And second, aflibercept is exceptionally good for poor visual acuity first line patients. Protocol 3 proves that 18.9 letter gain compared to 14.2 with ranibizumab. It's the strongest evidence for agent preference. Faricimab has no equivalent data. Aflibercept remains gold standard here. Faricimab best for durability and safety. We can achieve Q16 in 50% of patients or more by year 2. No vasculitis signal. Clean and safe. The preferred choice when durability is paramount and brolucizumab is contraindicated, and cost is the limiting factor in India, of course. Brolucizumab selective use, it has superior CST reduction. We can achieve Q12 dosing. It is offset, this durability is offset by the 3.3% vasculitis incidence and a high incidence of IOI otherwise, and venous occlusion, retinal venous occlusion. So detailed informed consent and immediate access to emergency ophthalmology is mandatory, and prior uveitis is obviously a contraindication. Thank you very much.
Uh, Thank you, sir. Thank you for a very insightful presentation and how elaborately discuss about the all parameter of all individual. It is really helpful for our audience for their insight and for their day-to-day practice. For what in what case what molecule should choose for their practice. So thank you. So now the session is open for the audience. If they have any kind of questions, or also our another speaker, Dr. Arnab sir, if you have any suggestion or any comment from your side. So session for now open for the audience. Thank you.
So it was a very unique presentation and a unique approach to the whole topic. And Shovik definitely has gone through the slides very in great detail. He's taken 35 minutes to present, but I mean, such a topic definitely warrants a good amount of time, and he has gone slow in trying and describing all the nuances. Just one thing, I think faricimab, one arm is basically ranibizumab. So
Yeah.
ranibizumab and at 4 times higher molar dose than the typical ranibizumab which we use, be it the innovator or the biosimilar. So if ranibizumab is not safe in renal patients, which you said, uh, if patients with low EGFR, I am quite certain that even faricimab should not be safe in such patients because it is one arm is exactly ranibizumab, just that it has 4 times higher molar dose. So if ranibizumab is unsafe in patients with low EGFR, then faricimab is even more unsafe. And that is one thing which I would want to highlight in spite of what Shobik presented in his presentation. So that is, I mean, this is from simple logic. I mean, I'm quite sure that there are no extensive studies on this, but this is from simple logic. But all said and done, somehow in all critical patients, uh, still most people still tend to go towards ranibizumab. Critical in the sense of not ocularly critical, but systemically critical, because it being a smaller molecule. It's basically fragment, antibody fragment. Systemic clearance is faster. So, where the patient is systemically challenged, where ranibizumab is still the molecule to go, but certainly aflibercept has many advantages. And as Shobik has so nicely elucidated in his presentation, much of aflibercept is clear to the hepatic route. So that is one advantage of faricimab beyond the other advantages of durability and potency. It's clear to the hepatic route, so a little safer, probably at least on paper, in patients with low EGFR, as you were trying to mention, Shobit. So
Yes.
my two pennies on all what you said, and it's a nicely presented topic. So without further ado, I move to my presentation. Abhishek?
Yes, sir. Yes, sir. You can start.
Yeah.
Thank you, sir. Thank you for your insights.
Your
Thank you so much,
screen is
sir.
still on display. I mean, you need to unshare.
Yes, sir.
Shobhik,
Yes, sir. I'll just share. How do I share this? 1 second. Um, it's frozen actually. Just 1 second.
escape, escape.
Yeah. Share. 1 second. It's frozen. 1 second.
Then you log out and log in again so
Yeah,
that
I'm trying
I
to.
can
So
proceed.
I'm trying to.
I am
Yeah,
requesting our
thank you.
tech team. Can
It's
you please?
fine, sir.
Thank you.
Yeah, I think it's now
Now
possible probably.
it's
Uh,
possible.
yeah, it would be possible for me. Abhishek, are my slides visible?
Yes, sir. It is visible, sir. Now it's comes in the presentation mode also.
It is,
It's changing.
yeah,
It's changing. Yes, sir.
yes, changing and it's full screen, right?
Yes, full screen. Right.
It's full screen. Just I'll raise this bar. Okay. So this is what I'm going to talk of. Tobig has actually covered a lot of the aspects that I was to cover. I mean, but such things uh, definitely warrant a repetition because these are concepts which only by repeatedly hearing and repeatedly going through that it sticks to our mind. So no harm in some repetition, and of course there is some additional points which I hope will be of help to my audience. So anti-VEGFs, as we all know, can be divided into conventional, which is ranibizumab and bevacizumab, and the newer, which basically covers aflibercept, brolucizumab, and faricimab. Several molecular factors determine how a drug interacts with the body, namely binding affinity, elimination, half-life, potency, clinical targets, and molar dose. Thus, these are also the 5 pharmacological strategies to try and achieve greater biological activity and extend disease remission by increasing binding affinity, increasing the potency, increasing the half-life, and having more pathways and clinical targets covered and increasing the molar dose. Now, talking about the first one, attempts to improve the binding affinity. The dissociation constant, Kd, is a measure of the affinity between two molecules, that is the ligand and the receptor, and tells us how difficult or easy it is to separate them. And since it's inversely related to the binding affinity, lower the Kd value, tighter is the binding. One can note from the table that aflibercept scores well here and has a VEGF A binding affinity of almost 100 times that of ranibizumab and much higher than the other anti-VEGFs as well. Binding affinity determines how strongly a drug interacts with its targets. And you can see aflibercept was found to have statistically higher VEGF binding affinity than balocimab and ranibizumab in a head-to-head study. A higher binding affinity can potentially lower the minimal efficacious concentration required to block a given factor. Now, the second point attempts to improve the potency. IC50 value, which is basically the half maximal inhibitory concentration, is correlated with drug potency. It is a measure of the concentration of drug required to inhibit a particular biological or biochemical process by 50%. Lower the value, more potent the drug. You can see from the above description that aflibercept is significantly more potent than volrustomig and ranibizumab in vitro. Now, talking of attempts to increase the half-life, half-life is largely a function of the drug size, and half-life changes the slope of the curve, as you can see in the line diagram on the left. Graph shows that a greater half-life allows a longer duration of biological activity in the vitreous of the eye. Thus, increasing the half-life results in increased intervals between necessary treatments, decreasing the treatment burden with any given agent. Uh, Estimated intraocular half-life in days, you can see that bortezomib, being a smaller molecule, loses out on half-life vis-a-vis larger molecules like aflibercept, though bortezomib attempts to compensate this by a very high molar dose. Uh, Talking of having more pathways and clinical targets covered, so basically, depending on what they block, we know we that there are single target drugs like bevacizumab, ranibizumab, and colocizumab. Dual target drugs like faricimab, blocking both VEGF-A as well as angiopoietin 2, and the multi-target drug like aflibercept, blocking VEGF-A, placental growth factor, VEGF-B, galectin-1. VEGF signaling pathway is the master regulator of pathological angiogenesis. For recollection, VEGF-A acts mainly through VEGF receptor 2, but also through VEGF receptor 1, whereas VEGF-B and placental growth factor acts through VEGF receptor 1 only. Angiogenic factors play a critical role in the development of edema, retinal vascular permeability, inflammation, neovascularization, and vessel stabilization. Activation of VEGF receptor 1 and VEGF receptor 2 by VEGF and placental growth factor promotes angiogenesis and neovascularization. As mentioned, aflibercept targets VEGF, the master regulator of disease pathology, and additionally targets the ligand placental growth factor. The FC portion of IgG1 extends the half-life uh, of aflibercept, and thus we get a long duration of action intravitreally. VEGF-A and placental growth factor are upregulated in exudative retinal diseases such as diabetic retinopathy, diabetic macular edema, and NMD. In patients with DME, VEGF levels are up by around 61 times, and placental growth factor levels are up by around 19 times. Why placental growth factor is an important target molecule, although other anti-VEGFs block VEGF molecules from activating VEGF receptors. Presence of elevated placental growth factor can activate VEGF receptors still. Could targeting additional pathways beyond the VEGF receptor pathway further improve efficacy outcomes? Aflibercept inhibits multiple targets, as we know. In previous trials, the platelet-derived growth factor receptor inhibitors have demonstrated no additional functional benefit vis-a-vis anti-VEGFs alone. And what about inhibition of angiopoietin 2? It is important to remember that levels and ratios of angiopoietin 1 and 2 VEGF-A are important determinants to vascular stability. Angiopoietin 1 binds and activates Tie2 receptors and is maintained at high levels in the healthy states, as we know. Angiopoietin 1 to Tie2 binding promotes endothelial survival and stability of cell junctions, thus stabilizing the vasculature. The angiopoietin 2 inhibits Tie2 activation by competing with angiopoietin 1 and is expressed at lower levels than angiopoietin 1 in the healthy tissues. And we know that VEGF-A binds to VEGF receptor 2. Basically, we should also keep in mind that faricimab is a bispecific monoclonal antibody that directly binds and neutralizes both VEGF-A and angiopoietin 2, effectively blocking their signaling pathway. Whereas aflibercept is a recombinant fusion protein decoy receptor that binds VEGF-A, VEGF-B, and placental growth factor with greater affinity than body's native receptors. Aflibercept is a decoy receptor, as I just spoke, that simply traps the signaling molecules which mistakenly bind with aflibercept instead of the original receptors without initiating a cellular response, therefore reducing activity. Is type 2 and 2 pathway a relevant target for treatment of exudative retinal disease? In high VEGF states, angiopoietin 2's antagonistic activity may promote destabilization of the blood vessels. However, in low VEGF states induced by anti-VEGF treatment, angiopoietin 2 may have limited relevance. In faricimab phase 2 trial avenue, ranibizumab and faricimab achieved Similar levels of plasma Ang2 inhibition after one injection. Data suggests that anti-VEGF monotherapy neutralizes Ang2 to levels comparable to that of directly targeting Ang2, supporting the belief that biological activity of Ang2 is downregulated by decreasing VEGF-A levels. This animal study, which evaluated the efficacy of anti-VEGF agents ranibizumab, aflibercept, and bortezomib in human VEGF 165 induced rabbit retinal vascular hyperpermeability model, it was found that Ang2 protein in vitreous and the mRNA for Ang2 gene in the retinal tissue were similarly suppressed, although the anti-VEGF agents do not directly bind to Ang2. Aflibercept demonstrated the greatest inhibitory effect in Ang2 levels in the vitreous, which correlated with strong, durable suppression of intraocular human VEGF levels. The results of this study support the hypothesis that Ang2 may be expressed secondary to primary insults to the retinal vasculature by VEGF. Bayer and Regeneron have investigated the Ang2 pathway in combination with aflibercept in the Ruby and the Onyx studies. Data from separate studies suggest that nesvizumab is a more potent inhibitor of Ang2 than faricimab. In Ruby as well as Onyx, targeting both the Ang2 and the VEGF receptor pathways did not provide additional improvements in vision, as you can see in the in the charts and on the line diagrams of both the Onyx as well as the Ruby. Uh, Thus, Ruby for DME and Onyx trial for NAMD program was discontinued primarily because combination therapy was non-inferior to aflibercept monotherapy for change in BCVA at week 12 and week 36 endpoints in both the trials. Unbalanced study designs favoring the faricimab and the additional Ang2 targeting with faricimab did not confer additional clinical benefit over aflibercept. It seems the activity of faricimab may be derived primarily from its ranibizumab arm. No proven clinical benefit with Ang2 inhibition. It could be that the higher molar dose of ranibizumab's FAB arm is responsible for the faricimab treatment effect. And this is what I was saying, Shobik, that you can see in terms of the ranibizumab arm, the equivalent molar dose for faricimab is 4 times that of ranibizumab. So if ranibizumab is kind of risky in patients with low EGFR, so should be faricimab maybe even more.
Yes, sir.
Attempts to improve molar dose. Molar dose is the amount of drug delivered at a single time, and increasing it moves the curve up. That is, the biological activity increases and stays for a longer time. Note the shift in the shift to a prolonged action with a higher molar dose. Increasing the molar dose has been a common strategy to increase biologic activity since the results of the pivotal Harvard trial. In the Harvard trial, ranibizumab at zero point 0.5 milligram versus 2 milligram showed that in the PRM arm of the study, the average interval between doses after the loading phase of 3 monthly injections was longer in patients who received 2 milligram. This suggests that administering a higher dose of intravitreal ranibizumab could result in longer biological activity of the agent. Similarly, increasing the dose of aflibercept to 8 milligram from 2 milligram, as seen by the two studies, PULSAR for AMD and PHOTON for DME, allows extending dosing up to 16 weeks immediately after the initial 3 loading doses. In regards to the vision gains, 8 milligram aflibercept, when given with extended dosing interval of 12 to 16 weeks, was non-inferior to 2 milligram aflibercept given 8 weekly. Thus, increasing the dose of aflibercept per injection alone has the potential to reduce treatment burden without compromising vision. Aflibercept delivers comprehensive and highly durable targeting where it matters, as can be seen from some real-world studies. RCT-like outcomes are possible with aflibercept in the clinical practice, be it the MOFUL study for NAMD, the Morimoto study for PCV, or again the Moorfield study for DME. So we know that aflibercept has become the benchmark for efficacy and safety with years of experience in clinical practice. So to summarize, aflibercept targets where it matters, VEGF and placental growth factor, thereby inhibiting downstream signaling via VEGF receptor 1 and 2, which is the master regulator of pathological angiogenesis. To date, both preclinical and clinical data suggest that there is no additional benefit of targeting alternatives to VEGF receptor signaling pathways. Separate independent studies suggest that aflibercept has a greater binding affinity for VEGF-A, a greater potency, and a longer half-life than the other available anti-VEGF agents. These factors contribute to the strong VEGF suppression we generally see with aflibercept. So, thank you for your patient listening.
Uh, Thank you, sir. Thank you for a very insightful presentation and how elaborately discuss the every slide of the slide deck. It is very helpful for our audience. So now the session is open for the audience and also for the Shobik sir. If Shobik sir any kind of question is there or any comment is there, so would like to hand over the session for the audience. Thank you.
There's one question that I had regarding the molar concentration. So if a particular molecule has a significantly higher molar concentration, but it is cleared primarily through the hepatic pathway, should we be very cautious even in such scenarios, even if it has a higher molar concentration? Let's say the primary pathway of clearance is through hepatic and not necessarily renal. Should we still be very circumspect before considering it in patients with chronic on under dialysis or chronic kidney disease within a certain range of creatinine, serum creatinine?
Yeah, I mean, basically, before, I mean, in patients with kidney disease, I generally try to find out what grade of kidney disease he or she has. Up to CKD, chronic kidney disease stage 2, where the EGFR is greater than 60, I'm okay. I do not necessarily ask the patient to go to the nephrologist and get a clearance done. But anything less than 60, that is basically stage 3 and beyond, I am a little hesitant in using any antivirus for that matter. And thankfully, at least for DME, we have a choice. There is a savior in the form of Dex implant, or even for patients who can't afford a triamcinolone in the right dosing, of course. But it gets difficult if a patient of renal disease also has advanced renal disease, also has a disease which only emanates with anti-VEGFs like a PCV or an AMD. So there comes the real challenge. So in such patients, what I mean, one, I definitely, if the patient with NAMD or PCV where there is no other option but to think of an anti-VEGF, and the patient has a CKD of stage 3 or worse, I give, I mean, if suppose the patient is a treatment naive, I will definitely start with a strong anti-VEGF. And my logic of starting with a stronger anti-VEGF there is to try and space it out more and kind of hit the disease hard so that I mean I actually end up getting a greater spacing. So one, I mean, beyond the other biological processes as to which one is getting cleared by what, I mean, like whether it's basically a hepatic clearance or a renal clearance. First and foremost, I don't want repeat shots and very frequent repeat shots of anti-VEGFs in patients with compromised kidney status. So for that, I will definitely start with newer anti-VEGFs, and then basically I write a note that plan to space out anti-VEGFs even in the loading phase a little bit more in view of renal status. And with that note, I send it to the nephrologist. because otherwise nephrologist will right away refuse any injection. So that will take the renal status, but will finish the eye. So basically, you have to put a note where the nephrologist knows that you also are concerned about the kidney. You're not just thinking about the eye, you are also concerned about the kidney. But as an ophthalmologist, I mean, of course, I'm parallelly concerned about the eye too. So I say, see, one injection of anti-VEGF will not spoil your renal status. It is only when we need to inject you repeatedly that things can start getting a little challenging. So first and foremost, I am promising you that I will space it out better. So let us start with a stronger anti-VEGF. And what you presented, Shobik, was quite an eye-opener that aflibercept is a good choice here. But thus far, what I have been doing was basically starting with a strong anti-VEGF, then maybe two shots of a smaller molecule like ranibizumab, and then again, if the disease is trying to run away, kind of trying to go the aggressive way, I again use one shot of a more stronger anti-VEGF. This is how I play around. When greater spacing, and I keep changing the anti-VEGF, and it has generally been a strong anti-VEGF followed by a, so to say, a less strong anti-VEGF. That has been the way I have played around, and thankfully, most of my patients have not really fared badly either ocularly or renally by this method. And since I have put a note, the nephrologist also understands the gravity of the ocular status and doesn't straight away veto out any anti-VEGFs. This is the kind of the small little tinkerings that we need to do.
Right,
In
sir.
DME, it is very simple. In DME, I will certainly shift to the steroids.
Right, sir.
Uh, but
Sir,
even in DME, suppose there is a PDR, so big, of course, even in a PDR, I mean, again, as I'm saying, one dose of ranibizumab or maybe even one dose of your aflibercept will not strongly worsen his renal status. It is only the frequent repeated dosing you're treating and keeping the patient only an anti-VEGF that has a higher risk.
yes,
But
sir.
having said, it is primarily the diabetics who have the associated renal issues. So, I mean, so basically, and thankfully in diabetics, we have a safe choice in dexamethasone implant.
So what is the main factor when you're looking at a patient with established chronic kidney disease? When do you generally recommend that we should have a look at the EGFR or prescribe the patient to have the EGFR looked at and then decide on the basis of that? Because we don't do it routinely for any patient, but I mean, a patient with established kidney disease, let's say naive, treatment naive.
Hmm.
What is your cutoff? Do you think that, based on what you're seeing, we should go for an EGFR for the patient?
I mean, even this, if you look in, I mean, if you look up on the internet, you'll find that the EGFR between 30 to 60 is stage 3A and B. So basically 60 to 45 is stage 3A and less than 45 up to 30 is stage 3B. So even
Right.
up to stage 3A, it is relatively okay. You can even without the nephrologist consent, maybe start with a potent anti-VEGF. It is only in patients with stage 3B who are still not on dialysis, that is a very difficult zone, because suppose you do something and the patient's renal status worsens and the patient from being managed with from being somebody who was just being managed with medicines lands up needing dialysis, then he or she might blame you for that. So stage 3B is the riskiest. Stage 3B is where the eGFR is between 45 to 30. So if you look into the papers of the patients have with them, generally it is mentioned as to what grade of kidney disease there is. If not, I mean, patients generally tend to have some reports where somewhere the EGFR has been done by the nephrologist or the physician. If not, get it done. Of late,
Right.
I have been insisting on looking into the degree of kidney status. The degree of kidney status.
Sir. Thank you, sir. Thank you, sir.
Yeah. Mm.
Thank you, sir. Thank you for a wonderful session, sir. So I think there is no question from other audience. So it's a good time. So thanks again for your valuable
Yeah.
time, Shonab sir and Shobik sir. Fully in future we'll again do this kind of meeting for the benefit of our audience. Uh, thanks. So now I
Yes, yes.
Yes.
now I'm
Thank you,
requesting.
Abhishek, for having us, sir.
Thank you, Arnab sir.
Thank you,
Thank you,
Abhishek. Thank
Shobit sir.
you. Thank you, sir.
Yeah,
So I'm now requesting our tech team kindly lock up this meeting link.
sure. Bye. Good night.
Good night, sir. Good
Good
night.
night.